Well, I think we're seeing lots of progress in myeloma with some new drugs entering the arena, particularly the monoclonal antibodies which target CD38. We will see data at this meeting of these antibodies used alone or used in combination with other drugs. These are moving quickly to late-stage testing, and I think will probably join the therapeutic arsenal that are available to us in the next few years. We also see some progress with a trial that will be presented with a histone deacetylase inhibitor called Panobinostat. It has positive results in its clinical trial. I think there are some issues going forward with respect to managing toxicity with the drug, but I think, again, nice to have a new drug with a new mechanism of action. We'll see some further updates on some other exciting new therapeutics which are coming, but still in their early phases of development. If one ignores the economics of the situation, I think we really need an antibody in myeloma to add to our proteasome inhibitors and immunomodulatory drugs to create an R-CHOP type of regimen for this disease. I think they will very quickly be adopted into the relapse and then the frontline setting. However, there are some economic issues. It's going to be very expensive to treat patients with all three of these classes of drugs, particularly outside the United States. I do think we have to look at some cheaper alternatives or more judicious ways of using these in combination. While high-risk disease still remains challenging, one of the tricks seems to be to use proteasome inhibitors for longer periods of time than we used to, up to 2 or 3 years of therapy, which seems to have some impact in controlling the disease compared to historical results. But what we do need really is a new class of drugs which overcome the high-risk genomics. And I think in that light, the antibodies are very exciting because they're agnostic to whatever is within the cell, and therefore they should be agnostic to the high-risk features. Well, oral proteasome inhibitors may be game changers as well, of course. The convenience of taking oral medication as opposed to coming to your doctor's office once or twice a week will be immense. On the other hand, early indicators are they're maybe not quite as potent as the intravenous or subcutaneous delivery of bortezomib and carfilzomib. So I think they may be best suited in the maintenance setting, in the treatment of the less robust, more elderly, more frail patient. I still think there will be a place for a more aggressive approach in younger patients.